Now, we focused a lot on the provider side of data convergence, but for financial, administrative, and clinical data to converge, financial administrative data from health plans must be supplied to providers, and providers must supply clinical data to health plans. But better exchange of data and the ability to use such data in a convenient manner is critical for value-based care. Many providers fail to recognize that health plans actually may have more information about their patients than they have themselves. For example, if a patient has been to multiple providers, the patient may not be asked for an enumeration of these experiences, or a patient may forget or even intentionally avoid identifying previous provider encounters. Even the ability to aggregate all pharmacy claims over a period of time can be immensely helpful where a patient has been on many drugs and may not be the best historian. Drugs previously tried and failed can more readily be identified and avoided, saving time, money, and most importantly, delay inappropriate treatment and potentially health risk. Similarly, health plans have traditionally closely guarded their claims data that reveals their medical necessity protocols and other claim adjudication processes. But being fully transparent with their claims data can help providers learn about issues that can get resolved and recognize practices they can change to improve the payment experience. Well, patient experience also, but payment experience for all. In value-based care contracting, knowing who should be in a narrow network of providers who deliver value-based care is an example and is also essential. Providers and health plans have a unique opportunity to converge their efforts toward achieving healthcare value. Providers do not have to take on the entire burden of supporting health versus their own domain of medical care. Recall our difference between health and medical. The example of Geisinger's provider-sponsored health plan prescribing food for those in need in their community is one that recognizes that health plans may have more resources to do some of the health-related activities. Providers, plans, and employers also may find that coordinating with one another within a community can strengthen ties to the local government's community service offerings and hence boost care coordination services through not only food but transportation services, wellness checks, and others. Last but not least, patients must be considered in financial, administrative, and clinical convergence. They are bearing an increasing amount of the cost of care, both directly through higher copays, higher deductibles, more uncovered services, and higher premiums, as well as indirectly through tax increases and the entire economic cycle of higher taxes meaning fewer employers, meaning fewer jobs, etc. Part of the equation in convergence must address value from the quality and cost perspectives, but two factors from the patient's perspective have important roles in value as well. First, patient satisfaction is playing a much bigger role in determining where patients seek care, especially as they are paying more for the care. There is significantly more advertisement and options for care, and the entire customer-consumer movement previously discussed means the hospital food has to taste better, nurses have to be more attentive, physicians have to be more compassionate, etc. Patient satisfaction surveys are relatively new, but have grown rapidly in importance. Second, and much more recently, however, it is coming to be recognized that while happy patients are a good thing, patients who perceive they got good value and are actually healthier are vitally important, not only to themselves, but to providers in a value-based care environment. Clinical outcomes cannot be fully evaluated immediately after surgery, on discharge, or even after the episode of care as defined in bundled payment has expired. And there has been little effort to study outcomes following any formal health care provider encounter. And of course, no formal process for collecting and documenting such data as part of a patient's healthcare experience. So, patient reported outcomes, or PROs, have emerged as a way to start collecting this information. Patient reported outcome measurements, PROMs, have been identified by NQF as factors associated with health related quality of life, including functional status, symptoms and symptom burden, such as pain and fatigue, experience with care, which is the patient satisfaction, of course, and health behaviors, smoking, diet, exercise, etc. Today, PROMs are just being introduced to the healthcare community, and there are certainly challenges that need to be overcome. Clinician reluctance to add to their workflow, belief that they know their patients, and concerns that patients will not be accurate in their reporting are perhaps the most challenging, as these are perceived beliefs by physicians largely that are not always valid. Concerns that measures should also include perceived needs, symptoms, response to treatment, undesirable side effects, and other factors that matter to patients are being considered for incorporation without being overly burdensome to patient reporting. Collection of PROs is largely via surveys today, precluding their convergence with EHR or revenue cycle management data in provider settings or with health plan data, unless, of course, they are brought into a data warehouse for feedback to EHR systems and health plan systems. It can be anticipated that much more research will be done in this area with new tools that will likely include more direct and hence precise measurement of outcomes in such forms as patient vital signs and remote measurements. Clearly, though, financial, administrative, and clinical convergence, not just of data but all stakeholder engagement, I think is new, exciting, and yielding of many opportunity. As always, references for this lecture are included here. We look forward to having you take the assessment for Unit 3 and working on the optional activity.